Thank you, everybody. This is my topic. Actually, this topic was presented in the ESC hotline presentation and then was published in the Lancet September. So my title is that option STEMI trial is timing of complete revascularization during index hospitalization in patients with STEMI and multivessel disease. So everybody knows that in the STEMI, half of STEMI have a multivessel disease, and the mortality after PCI for STEMI with multivessel disease is significantly higher compared with the single vessel disease. So many landmark clinical trials demonstrate that complete revascularization is superior to complete-only revascularization in STEMI with multivessel disease, mainly by reduction of new myocardial infarction and repeat PCI. So 2025 American guideline mentioned that multivessel PCI or significantly stenosis, non-infarct-related artery stenosis at the time of primary PCI may be preferred over the stage approach in the 2BB indication. In the hemodynamic stable patient and the low complex multivessel disease. So 2023, the European guideline mentioned that in a STEMI with multivessel disease, complete revascularization either during the index procedure or within 45 days is class 1 indication. So Japanese group CV expert consensus document also in patient with stable STEMI with multivessel disease, complete revascularization either during the index PCI or within 45 days is recommended. So you think about that and the immediate multivessel disease in the STEMI with the multivessel disease. So it's a greater convenience for patient, reduce vascular complications from repeated arterial access. However, in the immediate multivessel PCI can heighten the procedural risk from the already intensified inflammatory and the prothrombotic state. So this option STEMI is the optimal timing of CR remains unclear in patients with STEMI and the multivessel disease. Previous randomized clinical trial, BioVasc in the Lancet and the multi-stars in New England Journal of Medicine revealed that immediate CR was non-inferior to stage CR in patients with acute coronary syndrome or STEMI and the multivessel disease. However, most of these patients had received the stage PCI for non-culprit reasons after hospital discharge. The question arises whether the treatment effect differs between immediate and the stage CR during the index hospitalization. We aimed to assess the non-inferiority of immediate CR versus in-hospital stage CR with regard to clinical outcomes at 1 year in patients with STEMI and the multivessel disease. So we recruit 994 patients with STEMI and the multivessel disease. This is a non-impaired trial, open label controlled, and the primary PCI for infarct-related artery, and we randomized 1-to-1, the immediate CR, and then the stage in hospital CR. So primary endpoint is a composite of all-cause deaths, non-fatal MI, or any unplanned revascularization at 1 year. The non-infarct-related artery lesions with stenosis 70 and more by visual estimation without FFR. FFR evaluation is mandatory with 50 to 69% stenosis. So inclusion criteria is age is 19 more years, and the STEMI and the primary PCI within 12 hours after symptom development, and the multivessel disease non-infarct-related artery with diameter 2.5 and more, and 50% and more stenosis by visual estimation. The key exclusion criteria: cardiogenic shock and the unprotected left main disease with more than 50% stenosis by visual estimation, and the chronic total non-infarct-related arterial occlusion history or planned bypass surgery. So this is patient flow and the flow follow-up. In the 9 patient enrolled, In the immediate complete revascularization group, 10%. So 52 did not receive allocated treatment. And then the stage CR is 946 patient, and the 37 did not receive allocated treatment, 7%. So this is a statistical consideration. It's a non-inferiority margin of the hazard ratio 1.42 and type 1 error in 2.5 one side. In the follow-up duration 1 year, assume the dropout rate is 4%. And then we assume the 12 months instance of primary endpoint in the stage group is 10.5%. This is baseline characteristics. Is immediate CR, stage CR. Its age is approximately 66, 65, and the male is dominant in the approximately 8%, and the hypertension in the 9.9, 51%, diabetes 42, 41%. In the Kelly class 2 and more, its immediate CR is 34%, and the stage CR is 32%. Actually, Kelly class 2 and more is a much more high instance compared with the BioVasc in the multistars. In the left ventricle ejection fraction is approximately 50%. Total length of hospital stay in the immediate CR 4 days, in the stage CR 5 days. This is procedural characteristics. Laser access is 75, 76%. Guidance of intravascular imaging, 24%, 28%. Time to stage procedure, 3 days in the stage CR. FFR in non-correlated regions, the mean value of FFR is 0.86 in the immediate CR, and the stage CR is 0.85. So revascularization for non-correlated regions in the immediate CR 6.3 and the stage CR 55. So this is the clinical outcomes in the primary endpoint. Immediate CR 13.1%, and the stage CR in the 10.8%. Hazard ratio 1.24, and the P non-inferiority is 0.24. And then this is the secondary endpoint. It's the individual component of the primary endpoint. Death from any cause 7.5, 5.3 in the two groups. Non-fatal MI 3.9, 5.1%. Any unplanned revascularization 5.8, 5.0%. So no significant difference between two groups. The death from cardiac cause, non-cardiac cause, TLR, TVR, non-TVR is as follows. So this is a clinical outcome, secondary endpoint, hospitalization for unstable angina, heart failure, stroke is no difference. The acute thrombosis in the immediate CR 2.0%, and then stage CR is less than 1%. So this is a pre-specified subgroup analysis according to the primary endpoint between the immediate CR and the stage CR, age, sex, diabetes, left ventricular ejection fraction, number of disease R3, culprit R3, P2RB12 inhibitors, no significant difference between two groups. However, Kelly class 2 and more is the significantly high instance of primary endpoint in immediate CR compared with the stage CR. So this adverse event during the index hospitalization in the immediate CR, stage CR is no significant difference. Some cardiogenic shock, mechanical circulatory support, death from any cause. So this is clinical outcomes according to the randomization group in patient with and without heart failure. Actually, this is there is a revision period in the European Heart Journal, subgroup analysis. And then the immediate CR is significantly high instance of the primary endpoint compared to stage CR in patient with a heart failure. However, without heart failure, it's a comparable level between two groups. So the BioVasc in Lancet, they recruit in the non-STEMI and then STEMI patient, acute coronary syndrome, and the multi-stars NJM STEMI patient. And then this is also a non-inferiority hypothesis. And then the BioVasc stage CR within 6 weeks after index procedure. Almost patient was done, it's a stage PCI after discharge and the readmission. And the multi-stars also a similar situation. I discussed many times with the American the intervention is almost the American system. Usually they stage PCI the after discharge readmission. Then but option STEMI, we did the in-hospital stage CR. And then we also, the all regions with the 52, 69% diamond stenosis by visual estimation, we performed the FFR. So, but BioVasc multi-stars is immediate CR was not inferior. However, our group, option STEMI, the immediate CR was not non-inferior to stage CR. So study limitations is only East Asian, a high crossover rate, use of IV imaging is different between the groups, and the routine FFR still used for the acute setting is very debatable. So we used in the this FFR use and the different FFR timing. And then also non-inferior margin in our trial was hazard ratio 1.42, which is quite large, but in the many landmark clinical trial also used this some wide range of the hazard ratio. So this option STEMI conclusion is among patients with the STEMI and the multivessel disease, immediate CR was not non-inferior to stage CR during the index admission in terms of the instance of composite death from any cause, non-fatal MI, or any unplanned revascularization at 1 year. So the guideline, even though guideline mentioned that immediate CR is acceptable, immediate multivessel PCI is acceptable in the American guideline and also European guideline, I think that we're very cautious to use the immediate multivessel disease, STEMI, the multivessel disease. I think just only focus on the very hemodynamic stable with the Killer class 1, I think it's fine, but the Killer class 2 maybe is some hazardous. So we, this is our hospital, and then we, host in every year live symposium. So please check this one, and then if you want interested, maybe please come to my hometown. And I also try to ongoing studies option non-STEMI trial, option STEMI 2 trial. Option STEMI 2 trial is we will compare in hospital versus out of hospital stage. It might possible that in hospital stage PCI much superior than out of hospital stage, but in the maybe we have to conduct in the clinical trials in the future. And then actually I am a current president of Korean Society of Interventional Cardiology. So this is next year in the January the international conference in the K6 2026. If you check in the homepage, maybe we are very welcome to foreign the faculties to present in the topics in this conference. Thank you very much for your attention.